All right, guys, welcome to Therapydia's 11th episode of PTTV. My name is Joe Brence, and I'll be moderating tonight's discussion. Tonight's discussion is going to be in regards to the modern manual therapist. A couple PTTVs ago, I had the discussion with John Ware and Tim Flynn about the future of manual therapy and the direction of our profession. Well, tonight we're going to discuss how does a manual therapist incorporate some of this new information on pain science and neurodynamics into their practice. I'm joined by two manual therapy experts, Robert DuVall and Michael Timko. And I'd like all of you guys to ask us questions, either via Twitter or through the chat function on the Therapydia site. But before diving in, I'd like to introduce Michael Timko and Robert DuVall and let them tell you guys a little bit about themselves. Michael, if you want to begin.
Sure. First of all, Joe, thanks for inviting me and giving me the opportunity to participate in tonight's forum. Bob, it's good to see you again. I'm a physical therapist. I've been practicing for about 22 years. I'm a graduate of West Virginia University. I have my post-professional master's degree from the University of Pittsburgh. I hold faculty appointments both here at the University of Pittsburgh as well as up at West Virginia University. I continue to actively see patients primarily at the UPMC Center for Sports Medicine. I also see some patients at the Department of Orthopedics up on the campus of West Virginia University Hospital as well. I am a longtime member of the American Academy of Orthopedic Manual Therapists. I sit on that organization's board of examiners, and my primary mentor and good colleague was Dr. Richard Earhart, who basically I had the distinct pleasure of working for and with upon graduation from West Virginia some 20-plus years ago. Up until his recent passing a couple, 3 years ago.
Okay. Hey, thanks for that introduction, Mike. Bob, would you like to tell us a little bit about yourself?
Yes, good evening, Joe. Thanks for having me. Mike, good to see you again. I have been a physical therapist for 30 years, graduate of Emory University School of Medicine as a PT, and I am board certified in orthopedic and sports physical therapy, as well as being a fellow of the American Academy of Orthopedic Manual Therapists. I'm the residency and fellowship program director at Sports Medicine of Atlanta. Our focus has been primary care physical therapy, direct access, where I've coordinated the care for greater than 15,000 patients direct prior to physician intervention. Our fellowship and residency program strengths are in differential diagnosis and medical screening, and we also have a big focus on the actual competency to perform the direct access role. Our residency and fellowship program are unique in that they have courses fully dedicated to the process skills necessary to perform direct access to physical therapy.
All right. Hey, thanks, Bob. So to begin this discussion, obviously tonight's discussion is about the modern manual therapist. And Bob, I'd actually like you to take the lead on this because you're the first person where I heard this term phrased. How do you envision the modern manual therapist? What does this really mean? And how does the modern manual therapist differ from some of the older ideas of manual therapy or some of the practice ideas of manual therapy? What is a modern manual therapist?
Well, there's been an explosion of evidence that justifies and defines really our practice, and we as physical therapists are really at the mercy of the evidence that governs who we are and what we do. And with this renaissance of manual therapy evidence, it's clear that there's an expanding role and expanding skill set that we must include in addition to the traditional, more black and white orthopedic competencies. I think we're seeing the newer versions of prescriptions of advanced practice include these skill sets that might include such activities as interventionally the use of trigger point dry needling, the use of instrumentation like Graston techniques, of course, appreciating the entire patient with regional interdependence. Our unique macrobiological expertise prepares us to look at the whole patient, which not only biomechanically needs to be considered, but the psychosocial elements of the patient, with all the evolving evidence as to the needs of the patient psychosocially as related to movement sciences. Our curriculum includes courses in modern pain science that we're looking at the entire patient. This is not to be overlooked, the fact that we screen the patient and identify the psychosocial needs of the patient in a very unique way, using the different tools that are now available, everything from fear avoidance to pain catastrophizing type screening tools that we can use to modify the traditional approaches we've used in the past. The focus is on the patient gaining a better outcome. As we move from fee-for-service reimbursement more to a pay-for-performance model, considering the whole patient, both regionally independent biomechanically, as well as their psychosocial needs, the curriculum we prepare therapists with needs to reflect these competencies.
All right. Michael, what are your thoughts?
Well, I think the essence of what the modern manual therapist is essentially going to be looked at in terms of the role that the physical therapy profession in general may be moving more towards in terms of a decision maker and the portal to entry, if you will, the profession of choice when it comes to musculoskeletal conditions, as well as some other conditions as well. With that being said, I think the essence of what we're talking about in today's modern manual therapist is the clinical rationale and reasoning, and very much along the lines as what Bob was speaking of, the ability to take this very holistic approach, to be able to take this vision of the patient as a complete entity, looking at both the biological, the psychological, and the social aspects of what makes up that patient, and integrate those entities or those dimensions of that individual into a treatment plan that will allow them to get out of a dysfunctional state. So again, I think the ability to account for a variety of unique variables is sort of what is going to set today's modern manual therapist apart from maybe the traditional way of looking at things from a biomechanical or strictly arthrokinematic basis. Okay.
Hey, and I definitely appreciate when you guys talk about incorporation of these multiple variables. To the people watching and to you guys know that I'm huge on pain science and understanding some of these different non-specific effects that occur with our manual therapy techniques, and all these psychological variables that can potentially, confound the outcomes. I actually want to lead into my next discussion topic off of what we just discussed there. So when we discuss and we talk about all these different variables that influence outcomes, what are your thoughts with the clinical prediction rules? Clinical prediction rule says somebody fits these things, we should do something. It doesn't always take into account some of these psychological variables. I know that the lumbar manipulation clinical prediction rule does, but let's say that an individual had 5 episodes of low back pain over the past year, but they fit that clinical prediction rule, but when you do mobility assessment testing on them, they're a little bit irritable, a little bit too irritable. Should we still follow those rules, or should we take some of these psychological variables into play or into consideration before applying that rule? Bob or Mike?
Well, this is a great question, and it's one that should be in this type forum for discussion because there is no absolute right or wrong answer. Clearly, clinical prediction rules have value for us to appreciate for those that meet the criteria to fit the rule. At the same time, we have to be very cautious to watch for the subjectivity that can influence the rule. And there is this art component that we try to foster in both our residency and fellowship program that clearly master clinicians develop. And it's part intuitive. It's the role of intuition that has to still fit with the rule. The rule seems to be somewhat exhaustive and a great starting point, but we have to be cautious. It can inhibit critical thinking and clinical reasoning, i.e. it could become a crutch to which you immediately funnel everybody to that rule and you inhibit the evolution toward mastery. Your pattern recognition can be inhibited, I believe, with the use or overuse of prediction rules. So we must still remain open-minded to where we can consider those variables that are not tangible, that intuitively can be perceived by the art part of mastery that's necessary for advanced clinical practice.
Okay. Mike?
Along those lines, I think this is where we consider the broad spectrum of what patients are. And there's variability in a lot of what we see. There's a lot of variability in the conditions that we treat. There's a lot of variability in who we are as individuals along those lines. A clinical prediction rule in many respects is a guide. It identifies certain key features that could be present in any individual's presentation at a moment in time. Clinical prediction rules exist in the presence of their exclusionary criteria, but in addition to their exclusionary criteria, I think there also needs to be the recognition that there are other moderating factors that go along with that as well. And part of that can be the patient's own beliefs and attitudes about what manipulation can or won't do, or it could be beneficial or it could be potentially harmful. And all of those things are going to come together in terms of being able to create a treatment effect. Bottom line for therapists, and as we're asked to intervene with patients, we need something that's going to help guide our decision making, realizing that there's always going to be rooms on the edges or the fringes for these moderating factors or moderating variables. And that's where I think the enhanced decision making comes in. And sometimes that can only be developed through time and repetition and experience, and not necessarily, directed or described, in a classroom setting or in a teaching setting or things of that nature. I mean, that's the essence, and I think a little bit of what Bob was talking about, the art of clinical practice to a certain extent. And again, those things are significant at times, but to the same token, we also need things that will drive practice, that will lead us to treatment decisions, rather than, the biggest problem we have out there right now is the variability in care. And again, this is where we start going out on the fringes too far, and we start accounting for anything but, or I should say all things, including the moderating variables. And now we end up with, instead of recognizing patterns, we end up making exceptions all the time. So again, there's room on both sides of this argument. That certainly is a bit of a challenge, particularly for those of us that are educating. What is the shade of gray? And when are we talking about something that's relatively black or white?
Okay. Hey, I appreciate that. Now, to build on your answer there, Mike, you discussed a little bit about the variability of care that occurs in the skill set of physical therapy, and let's talk about modern manual therapy here. So there's different groups of manual therapists out there. There's some that are strictly holding on to more biomechanical principles. Some groups are just saying manip it and move on. If somebody fits this rule, it's a no-brainer. Let's just do this technique. And there's other schools of thought that are saying we need to identify the patient's response. We should let the patient's response guide our interventions. Where would you guys say that you're lying in terms of how we should be approaching or how we should be intervening in these individuals? Bob?
Well, I would start by saying that the clinical prediction rule serves as a wonderful starting point for us to consider and apply as applicable. And with experience, as we identify and sense with the art part of practice, the individuals that don't directly fit the rule, that modification needs to occur. But again, I would argue it's a great starting point and has its role. We just don't want to inhibit the critical thinking by having a plug-in, ready-to-function rule that could stagnate the evolution of advanced innovative type practice. And the rule itself would not be developed if it wasn't for someone having the risk involved with innovation to create and basically apply the art part to the science. So we have to balance it very carefully. I think it has its place again, and we just have to be critical thinkers, though, throughout this whole process.
All right.
I think the other thing that we have to recognize is that even within our own body, you know, for example, let's take a look at the pelvis, for example. There are certain biomechanical factors, landmarks, clinical assessment procedures that might be readily available there that wouldn't necessarily be as applicable, let's say, in other areas of the spine. I think being able to make use, stealing from one of my athletic analogies here, you know, taking what the defense gives you, so to speak, sometimes. Looking at regional factors, looking at what variables lend themselves best to identifying states of dysfunction in these various regions of the spine. I think this tends to open ourselves up more towards a more eclectic version of what you're talking about here, Joe, as opposed to being strictly driven, let's say, by a biomechanical model or a pathoanatomical model that may or may not have the same relevance or variance, especially as we start considering the regional differences throughout the spine, you know, as well. So again, I think the more we can combine elements of what you talked about, you know, anatomy is still a key. Anatomy in some respects is still a constant. But what we're able to put hands on, what we can adequately assess, what we can rely on patient feedback, you know, these are still elements that I think all need to be looked at and continue to be developed further and not necessarily become locked into one mechanism or another.
All right. So to shift what's that, Bob?
So, you know, we haven't looked at the studies critically, perhaps, and revalidation and validation studies. There's design flaws, one could argue, when we look at the actual methods to which some of the rules have been drawn. And until we have adequate revalidation and validation studies to justify some of the rules, I think we still need to be cautious with some of these rules. While they have their place, I think some of the rules have been designed such that you could critically look at it with flaws in their design. So, and looking at everything from the type patient populations that have been used doesn't always draw a direct one-to-one ratio with the relevance to clinical practice. So we got to look at it from a critical inquiry perspective also.
Okay. Now, to shift the focus a little bit in this discussion, Mike, you teach the treatment-based classification system for low back pain. Are you able to explain this a little bit further to the viewers?
Sure. The original intent behind the treatment-based classification system was to provide a construct and a foundation by which you can look at a patient presenting to your clinic with low back pain and ultimately lead to an initial treatment decision that primarily focused, at least in the early makings, on really what we refer to as stage 1 or pain modulation primarily. What has really gotten lost in translation over the years as the system has been studied and developed further and evolved was sort of one of the original concepts, which was this aspect of staging, where a stage 1 patient was considered to be someone that was in a more irritable or acutely painful situation. And the primary crux of treatment at that point in time was to identify strategies to help modulate that presentation and to prevent any worsening of the patient's status. And upon stabilizing the patient's clinical status, progression then to stage 2 or stage 3 was the next goals of treatment, with stage 2 being more of an impairment-driven indice and stage 3 being more of a functionally driven stage or indice. And over time, a lot of attention got put onto the development of the stage 1 principles, and sometimes at the expense of some of the other stages, and I think in some respects actually shortened the reach or shortened the ability of the system to accommodate the variety of back pain patients that are out there. That being said, if you go back and you look at the fundamental construct and outline in the original algorithm, the first decision that therapists were asked to make was that of appropriateness, which I think, again, in today's environment is very reflective of this issue of medical screening and potentially differential diagnosis. So even back in the early 90s and actually going back to the late 80s, there was discussion or at least some vision forward of trying to have a system whereby therapists had the ability to identify things that would probably be most apt to respond to physical therapy interventions and those things that probably needed to be referred onto other medical colleagues. The next decision that was going to be made after this appropriateness stage was then where were they in terms of stage 1, stage 2, and stage 3. And then the last order of decision making then was really within stage 1. Where did the patient fit and which strategy for pain modulation best represented that patient's current clinical picture. And it's been that arm of the treatment-based classification system that has continued to get an awful lot of attention and development, but as I said a little bit earlier, maybe at the expense of some of the other concepts that were embedded in the original design.
All right. Now you're talking a little bit, Mike, about you know, there's been kind of an evolution to this classification system. Where do you see it going? Do you still seeing it being applied clinically with therapists? Where is this fitting in right now into, you know, current clinical practice for the modern manual therapists?
I think the components and the elements that are there and within the system still offer a very strong foundation in many regards, although some of those pillars have not been developed as well as they probably need to be. For example, very early on in the workup of the patient, going all the way back up to the initial stage of appropriateness, there were the recognition, and again, back in those days, it was the Waddell's components and the Waddell exam. And that was actually part of the early system. Today, that has been looked at as far as the FABQ, but in terms of what else to do and how else to integrate that and how to look at that arm, rather, you know, thinking about it as a separate arm versus having that component be a component or a part of all patients that might be you know, who we're looking at and who we're diagnosing. Again, this is what I mean by the development maybe not being fully appreciated. You know, this idea of sort of segmentation or selectively taking patients and putting them into a category and sort of leaving them there, and not necessarily accounting for the fact that this is a fluid dynamic.
Exactly.
The essence of classification is that the patient's status and their clinical picture is expected to change and evolve within the episode of care. and that needs to be reflected in our decision making as we work with this patient through this evolution during that current episode of care. And again, I think that's something from a research perspective that is very difficult to capture, has always been a part of the treatment-based classification system, but really has not necessarily been able to get adequately translated over time as the system has gone through its various evolutions here.
Yeah, I think you make some really, really good points there, Mike. I know that when I was in physical therapy school, I learned the treatment-based classification system, and you kind of classify somebody into a certain group and really don't know when to progress them. And then when I went to some manual therapy courses, I went to Maitland, Australian seminar route, and learned how important that reassessment is, how important it is to look at within session changes, how important it is to look at between session changes. I think that the modern manual therapist has to really take those things into account, because otherwise we can kind of get in this rut and have somebody doing the same things or getting the same techniques session after session, when your nervous system and your body's constantly adapting to the variables that are being applied.
Yeah, and it's interesting that you say that along those lines, Joe, because having been brought up clinically within this system, I mean, essentially I started clinical practice back in 1990, before the system was actually published, and having been around some of the principal authors of the system my entire career, this is something that I certainly have a unique perspective on. But I can honestly say this, that in clinical practice, every encounter with the patient immediately started with a reassessment. That was basically the way that I was brought up clinically. One of the things that I truly learned to appreciate, and I took from Dr. Earhart in my clinical development, was exactly that, and that the expectation that a patient's status should change in response to intervention was really what we were looking for. And essentially, did we get this change that was consistent with expectation, yes or no? And that would oftentimes then drive the next step in the equation. So I agree with you wholeheartedly that this sort of continual reassessment is probably the essence of classification. And it's probably the concept that has gotten lost, as I alluded to earlier, in translation to a certain extent. Because again, when you look at doing a research study, you're breaking off a moment in time, not necessarily the episode of care. And subsequently then we make determinations or we make conclusions based on that moment in time that again may not always be representative of the entire episode of care.
All right. I appreciate it. So moving on, we have about 15 more minutes, guys. Bob, I actually want to direct this one to you, and then Mike, you make a comment as well. And actually, Mike, this is based off of one of your students at the University of Pittsburgh, John Snyder. He's a blogger and has this blog, Orthopedic Manual Physical Therapist, or orthopedicmanualpt.com. And he just wrote this article, Is the Juice Worth the Squeeze? And he's regarding to cervical manipulation. Is it necessary? And if it's necessary, who do we apply it on? I know that Louis out of UNLV, he just recently published a clinical prediction rule on who we should provide a cervical manipulation to. But is it truly necessary? Do we need to be incorporating cervical manipulation into practice? Bob?
Well, I would never say always or never to any clinical intervention. There seems to be a certain population. For our ability to identify what is the appropriate population is the challenge. Needless to say, I've had many patients respond well to cervical manipulation. Obviously, we have biomechanical and neurophysiologic effects that are well documented and a strong scientific basis for that intervention. At the same time, there are other interventions that equally can achieve similar outcomes that we have to keep our eyes open. So there is no one absolute rule, I believe, to follow. I think the art part of practice is still significant in that realm. I'm very pleased to see these studies evolve, though, that seem to help us with selection processes.
Okay, Mike?
Well, and again, I think this speaks a little bit to what I was alluding to a little bit earlier in tonight's discussion with regards to these regional differences sometimes within the spine. You know, you look at a more stable weight-bearing lumbar region, lumbopelvic region, versus a more mobile, more dynamic, more fluid cervical region. Does one area of the spine lend itself better or respond better to thrust joint manipulation as opposed to the others? What is the underlying mechanism between which segmental dysfunction or mechanical dysfunction in these areas actually manifests? There are some that are out there that believe that the cervical region is probably a little bit more dynamic in terms of neurophysiological and muscular influences, maybe a little bit more so than, let's say, the pelvis itself. So again, I think these are still questions that need to be asked. I think thrust joint manipulation is a valuable tool, but again, I think the important aspect, as it is when it comes to applying any tool, is knowing what circumstances that tool is best suited for. You know, if all I have is a hammer in my toolbox, I certainly have a tendency to make everything want to look like a nail, don't I? But if I have multiple tools in my tool bag, I may start to think which one of these tools is best suited for the presentation in front of me. So again, the clinical assessment, the clinical decision-making, the understanding of who that patient is in front of us becomes paramount.
All right, I appreciate that, and you know, some of the discussion that's came about from that article that he wrote was, you know, are cervical manipulations, are they safe, and are there safer alternatives that get similar results? Real quick, your guys' thoughts: are they safe? Do we have enough documented evidence to indicate that they're not safe?
Well, again, medical screening becomes key here, trying to identify, one, are there any contraindications to cervical manipulation? And I think we have strong guidelines that we know what the indications and contraindications are, so the risk to benefit ratio has to be decided on each individual client as we look at it with our decision-making rules. So they definitely have to be taken into account, and obviously, above all, do no harm. But at the same time, the master clinician is able to identify and take prudent risk in the interest of the patient. Well, one could argue by being ultra-conservative, insidiously, we may be doing more collective harm in that capacity. So the risk to benefit ratio seems to be one of those competencies we develop a strong appreciation for with clinical experience that we need to have. But in the meantime, clearly the indications and contraindications and the rules and tests that we must administer prior to cervical manipulation have to be performed carefully and effectively.
All right.
Again, I would echo those same thoughts. It really comes down to patient selection and so forth. There are really a number of studies that have come out that have pretty much dissuaded this issue of risk and safety to a certain extent. When you look at incidence rates, when you look at some of the work that's been done by Cote and Cassidy, where they've looked at thousands upon thousands of patient records and looking at the relative incidence of adverse responses and so forth, you know, again, the issue of safety I don't think is as much of a concern or a question, but it will always come down to, are we selecting the appropriate patient? And I think the other side of this that we also have to think about too is there's a certain amount of finesse and polish and acumen on the hands of the operator in terms of being able to skillfully apply their craft, because even if we select the correct patients, but I'm not well trained, I'm not well versed, I'm not proficient in what I'm doing, you know, there is a potential risk of harm that will always be there. So can we negate the risk? No, we can't eliminate it, but I think we can control for it by being wise, by being prudent, and being skilled in the treatments that we administer.
All right, and you know, along the lines of improving the safety of our techniques, both you guys are involved in some postgraduate work in terms of, Bob, you're the head of a residency and fellowship program down in Atlanta, and Mike, you have this COMT certification, you know, course series that's coming up. Why is this important? Why is it important to get further manual training after graduation to some of the new graduates out there that are watching, or maybe some of the students that are watching?
Well, I'd like to comment first that I'm so happy that CAPTI is now requiring programs accreditation to include manipulation in the entry-level training. And while it's been a long time in our curricula, for all programs to have this requirement is a great starting point, and that's just what it is. Clinical practice obviously doesn't end at graduation. The clinical education becomes extremely important as we evolve, as our skills evolve. We should have some form of mentorship and practice, and that's what really residency is and fellowship programs are, that we look at going to subject matter experts and picking courses and constructing curricula that will lead you to a mastery. And we now have the provision of doing that distance-based, right where you work. We have a program called Residency During Lunch. Actually, it's between noon and 2 on Tuesdays. And the didactic component is disseminated during this 2-hour time once a week for a 9-month period of time. This is then carefully coordinated across practice settings with mentorship curriculum that enables the practitioner to continue to evolve while in and during clinical practice. So I would argue for the first time in my 30-year career, I'm seeing the selection of your continuing ed to be more relevant than it's ever been. One, related to the sophistication and integrity of the skills that we now use and incorporate. Two, the shift from fee-for-service to more of a pay-for-performance with healthcare reform will become very relevant, and thus the portfolio you develop after graduation becomes integral. And the mentorship and the relationships you develop with clinical practice as you evolve toward mastery will obviously affect your outcome, batting average. That transparency and accountability will be key parts of this reform, and therefore your clinical competence becomes relevant. So all of a sudden, clinical education has many different roles than what it historically has had. It's simply getting you your license renewed. And so these residency and fellowship opportunities, the feasibility and accessibility of them, along with structured mentorship and approved curricula that's monitored by APTA and the American Board of Physical Therapy Residency and Fellowship Education, all become relevant.
All right, Mike?
It's a tremendous challenge what the PT schools are faced with when you look at what the CAPTI requirements are, and you recognize what we as a profession are in terms of the breadth of our care that we provide, everything from pediatrics through neuro rehab to manual therapy to prosthetics. It is an enormous undertaking to bring a generalized practitioner up to the level of competency, which is really what the DPT program is all about. That being said, as an individual moves then into their selective vein of clinical practice and expertise, it only makes sense that there needs to be viable mechanisms out there whereby skills, critical reasoning, thinking can be fostered and developed to the level well beyond what the entry level or the first professional experience provides. And that is really what I think the strength of a structured continuing education program is all about. This is really what residency and the model of residency is predicated upon, is being able to take practical experience to be able to bring the individual now to the clinical environment rather than trying to bring the clinical environment into the classroom, and really learn to develop the key principles, the key decision-making criteria, the key assessment skills and treatment skills that will require expertise. And as Bob alluded to, as we shift to pay for performance, this is what the expectation is going to be. This is what the public is going to want from their physical therapy encounters, to be able to come in and make a difference in a very cost-effective and efficient manner.
All right, so guys, we're just about out of time. I'm going to give you guys each about 30 seconds, and we're going to start with you, Bob. In 30 seconds, I want you to tell the viewers, why should they become a modern manual therapist? Why is this important to the practice of physical therapy?
I would say accountability, patient-centered care is in the forefront. We are evolving from astute clinicians to become clinical scientists, those that are able to first and foremost discern that the patient is at the right place, i.e. that they have a mechanical impairment limiting her at the right place. Second, to create a movement-based hypothesis which you can account for and identify what are the direct evidence-based interventions toward those impairments to make a measurable change, to actually measure the change and account for a significant improvement of outcome that is worthy of taxpayer reimbursement, that enhances quality of life. These are large issues with our social responsibility as physical therapists to fulfill, and without the skill sets for both the examination, the evaluation, the diagnosis, the intervention, the prognosis components, you're going to be ill-equipped. We now have, like we said, convenient mechanisms that will education in a
Bob, I lost that last portion of you. Mike, do you want to take off there and tell us
your
thoughts?
I think the one thing that, and I think anybody that takes on the profession of physical therapy inherently has this want and has this desire to do right by their fellow man, to be able to make a difference, to be able to provide a sense of symptomatic relief, to be able to improve one's functional sense and functional well-being. And this is the tremendous capacity that we as physical therapy therapists possess. And you're seeing this differentiation across all aspects of our field right now. As our scientific base has grown, as our evidence regarding practice has developed and grown, there's been this explosion of information that we need to be able to make sense of, put into practice, and more importantly, be able to affect in a very positive way our fellow man. Again, we have a very unique opportunity with the healthcare reform that is on the horizon here, and the skill set that we as physical therapists potentially possess to develop that to its fullest extent and be able to play a very significant role in the health and well-being of all individuals, I think is really the quest for all physical therapists. And to be able to foster that in any way is certainly something worthy of attention.
All right, well, it looks like we're out of time, guys. Mike and Bob, thanks for joining me this evening for this discussion. On behalf of Therapydia, we're going to take off from this episode of PTTV. If you have any further questions, you can continue the conversation on Therapydia.com or on forwardthinking.com. Thanks, guys.
Thank you, Joe.